Good morning, good afternoon, good evening, wherever you may be. My name is Ann Brazo. I'm the CEO and founder of MPN Advocacy and Education International. Today, we are going to be talking with Gabby Hobbs, Dr. Gabby Hobbs from Mass General. She's going to talk about approaches to symptom management, which I know is a huge topic for all of our MPN patients as the list of symptoms keeps getting longer. One that we heard the other day was that if a person gets the flu or a cold, it lasts much longer than the average person without a blood cancer. That's just one thing. You know, we know that eyes can be affected. We know that everything in your system can be affected by an MPN. We're waiting for Gabby to come on. We have lots and lots of questions. If you have more, please send those. We're going to try to get to all the questions. She's not going to do slides, and so she will just be speaking to you, and then we will go on from there. We also, I want to share with you some other webinars coming up. And after this, on February 10th, Dr. Gertz, who's been with us many, many times, is coming on Monday, February 10th, from 11 to 12, and he's going to talk about everything you want to know about your MPN. So you can ask any question you'd like. And then for our pediatric and young adult people with an MPN, we have Dr. Nicole Cuisine and Dr. Linda Rizar to discuss pediatric and young adult MPNs and the challenges that you face, but also the new things that are going on in research for younger people. And that will be Thursday, February 20th from 12 to 1 Eastern Standard Time. And then finally, or then in March, we have Dr. Rajit Rampal, who will be discussing your blood work and how to understand it. So when you get a CBC, what's happening? What are we looking for? What does the slide look like if you have ET, PV, or MF? All of those questions will be answered by him. And then, of course, your questions. And that's on Tuesday, March 4th from 4 until 5. And lastly, in March, we have women's issues and complications related to MPNs if you're female. And that is Thursday, March 27th from 11 to 12 Eastern Standard Time with Dr. Chi-Joan Hao and Dr. Nasemi Gangat, who they have written great papers about women and MPN. And so we're very excited to have them. And so we're still waiting for Dr. Hobbs, but she will be here. It's always, you know, touch and go sometimes because of the patients they see in the mornings and some of the lab work, but sometimes they get stopped because of the questions they have by other patients that they're working with right now. So some of the other things we can share with you, first of all, we're also going the 3 in-person events. We have one coming up on March 14th, 13th, 13th, sorry. March 13th, that's a Thursday in Tampa, Florida at the Marriott on the Water. And we hope that you can join us. And here's Dr. Hobbs. And so good morning, sweetheart. And we have so many questions for you.
Oh, good.
Yeah. So this hour is going to fly by. And of course, people are still asking questions. We had over 200 people sign up for this, Gabby. And so thank you so much, so much for joining us. We love you and we're always happy to see you.
Oh, thank you so much, Anne. I feel the same way. I'm sorry I was a few minutes late just dealing with a patient call.
That's exactly what I said before you got on. I said, you know, they're still seeing patients and talking. And so we have to be patient.
I appreciate
that. Anyway, I'm going to jump right into questions for you.
Okay, great.
And the topic is, you know, looking at different approaches to symptom management, but of course, any of your questions are welcome. Okay. All right. So the first question, there have been some recent studies that link cardiovascular issues to MF. Is there anything MF patients can do?
That's a great question. And I would say just more generally, patients with myeloproliferative neoplasms are at risk for having cardiovascular complications because of their disease. So when we talk about blood clots, that's exactly what we're talking about. You know, we're talking about um, heart attacks and strokes in addition to blood clots in veins. So in terms of, is there anything to do? I think an important thing to remember is that you aren't just a patient that has an MPN, you are also a patient that has a cardiovascular system, and you are at risk for having high cholesterol or diabetes or high blood pressure, et cetera. And so making sure that you still have a primary care doctor that can help you manage that is really important. So your MPN team will manage the myeloproliferative neoplasm, but your cardiologist or primary care doctor will help you with the other part. And, some of us try to do studies looking at both, but there's no substitute for having a good primary care doctor to keep your cardiovascular system healthy.
That is so correct. And yes, as you know, Ellen Ritchie did some studies with women in cardiovascular issues who have MPNs, but a lot of our MPN patients do have a cardiologist on board as well. Thank you. This person says my allele burden is at 4%, but my physical symptoms are worse now than when it was at 22%. Can you explain why?
It's a great question. And I mean, I think that it goes to say that the allele burden is still a mystery. And even though we want it to be very quantitative, same as the blood counts, if my blood counts are better, then I should be better. If my allele burden is lower, then I should be better. It's not that straightforward. We have patients with allele burdens of less than 1% that present initially with a, almost life-threatening blood clot. And so the allele burden doesn't tell the whole story. But along those lines, symptoms are also multifactorial, meaning many things cause that. So if a patient has other medical issues that are keeping them, for example, from sleeping, they're going to feel really fatigued. And so no matter how well controlled their MPN is or how wonderful the medicines that they are can be at controlling their disease and their symptoms, no amount of medications for your MPN is going to fix the fatigue that you have from not sleeping. And so I think that making sure that you have a conversation with, again, both your primary care doctor and your MPN group about what may be making your symptoms worse is really, really important.
Absolutely, yes. Why is aspirin the only recommended blood thinner for PV patients?
So aspirin is not a blood thinner, but it blocks platelets. So blood thinners are a different group of medications that are called anticoagulants, but aspirin is probably the most commonly used medication for prevention of blood clots in the world. And that includes in the general medical population also in terms of, preventing heart attacks and strokes. So aspirin has been studied for MPNs and has been shown to lead to less cardiovascular complications, including heart attacks and strokes. And so that's why that's the medication that is utilized. It is a inexpensive medicine that is generally well tolerated. And so it's hard to be better than a baby aspirin at blocking the effects of platelets. And really the abnormality in MPN is more related to the platelets than the proteins that do blood clotting. And so that's why we don't give blood thinners, we give aspirin.
This question, I think I could answer in you. Are there any clinical trials coming up for patients under 40?
I mean, I think clinical trials include patients under 40.
Yeah.
In terms of being designed specifically for patients under 40, there's not enough in that space for sure. I mean, MPNs in younger patients are not that common. And so to design a clinical trial just for younger patients would probably be difficult. I'm not aware of a study that's just for younger patients. There are studies looking at younger patients more related to surveys and, the impact of the MPN on their disease, and especially for younger women, looking at, issues related to conception, contraception, and menopause, not for the younger women, but specific medications just for younger patients, not as much. We're working in Boston at designing a clinical trial for patients with what's called CHIP, where the patients have a JAK2 mutation but don't have an MPN yet, to see if we could treat that, before it becomes an MPN. And so that's going to include a lot of young patients, but there aren't clinical trials with new medications that I'm aware of just for patients under 40.
Yeah, I know. I mean, I know the pediatric part of it, with Nicole and Linda Razar, but
But
Yeah,
even
because
with the two of them, I'm not sure that there are clinical trials specifically for that
yeah, I
indication.
think Linda does, but not necessarily 40s, like probably peds more,
Yeah,
pediatric, like,
yeah.
children. Is anyone looking at GLP-1 meds for inflammation caused by MPNs? I started taking tirzepatide and my lower leg numbness disappeared.
Wow, that's really, really interesting. Not yet. These medicines haven't been around for that long, but we're definitely interested. So stay tuned.
I'm seeing stuff I haven't seen for a while. How does DMNT3A complicate those with CALR?
It doesn't really. I mean, DNMT3A is one of these, again, going back to this phenomenon called CHIP. So CHIP is when people have a mutation, but it doesn't impact their blood count. So many people can live with mutations, but don't not have an actual disease. And so DNMT3A, along with TET2, are two mutations that exist in this state called CHIP. And they may impact cardiovascular outcomes. With DNMT3A specifically and MPN, it's less clear how it really impacts things. So I wouldn't really worry too much about it, to be honest.
Getting back to the young adult, this question is, are you seeing an increase in young adults diagnosed? And are there different guidelines for this group? We're seeing an increase, definitely,
Yeah.
between 18 and 25. And I'm not sure, you can answer this, obviously, Dr. Hobbs, and that is there a different protocol for younger people in terms of treatment options and treatments?
Yeah, no, that's a great question. I mean, I think that because um, we have more available genetic testing, and primary care doctors are more aware of that, more patients are getting diagnosed. So it's not so much just that younger patients are getting diagnosed, it's just that people in general are getting diagnosed earlier because
Mhm.
almost anybody now can order genetic testing, specifically a JAK2 test.
Mhm.
And so I think people are getting picked up earlier, which means then by definition, younger people are being picked up earlier as well. I don't know that that necessarily means that the actual incidence has changed over time, or we're just recognizing patients that before would have gone undiagnosed. And in terms of if there's a different protocol, there should be a different protocol, but we don't have a different protocol yet. So to some degree, interferon has kind of, you know, found its role in potentially in younger patients, and I'll tell you what I mean by that. But the guidelines basically separate patients on whether or not they're 60 or younger, you know, and so that's a wide range. It's very different to think about a 57-year-old than to think about a 22-year-old.
Mhm.
Um, but roping interferon or BESREMi was approved for patients with low risk polycythemia vera, for example. So that I think that's a start in changing the paradigm where, just because you're younger and have low risk disease doesn't mean that there aren't medications that you can take to make a difference in your disease. Um, and so I think things are starting to change in that direction. But as of now, like I said, the main differentiator up to now is, are you over the age of 60 or are you younger than 60? But
Yeah, yeah, I know that some folks are really starting to look at this because we've gotten a lot of younger patients that are in the workplace that are really under a lot of stress and very concerned about work and their families and are they going to get fired if they know they have this long-term chronic blood cancer? And so we're really trying to address some of those issues and have some roundtable discussions about it and how we can mitigate some of those fears. But can you comment further on the recent learning impacts of the TP53 mutation on MF, such as recommended treatments, VAF percent, and the SCT timing? And that's always a question about transplant, right? When is
yeah.
the right time to transplant? And when we're in Florida, Dr. Nishori will be talking about transplants and MPN patients, as we always try to bring that subject up. What are your thoughts, Gabby?
Yeah, those are a lot of different questions in one, so let me try to get
Yeah,
them.
it
So,
is. There
mutations
are,
play a big role in prognosis of MPN patients. And
yes.
so, not just P53, but others. P53 is a poor risk mutation. And if you have one P53, it's better than if you have multiple. These are not things that you choose. So if you have them, it's just what it is. They do play a role in determining your prognosis, and then by definition, they play a role in determining when you should go to transplant. There isn't an easy answer to say when I should go to transplant. This is a conversation to have with not just the myeloproliferative neoplasm doc that you see, but also with the bone marrow transplant doctor that you're seeing. And so along those lines, I would say if you are a patient with myelofibrosis, it is important for you to understand and to have asked your doctor, do I need a transplant now, yes or no? And if they're saying no, it's important to understand what is driving that no. Is it that your doctor is just not that familiar with sending patients to transplant? And if that's the case, ask for a referral anyway. Because outcomes for patients with myelofibrosis have improved significantly over the last decade with regards to transplantation. And although there are a lot of excellent new medications that are being studied, in 2025, the only curative therapy for myelofibrosis is a transplant. And so if you are eligible for a transplant, and if you have high enough risk disease, then you should be considered for a transplant. And I think that's part of being an advocate for yourself or for your loved one, is asking for that. It's scary. It's scary to think about it. It's scary to talk about it. But honestly, I think that the best antidote to fear is information. And so talk to the docs. That's what I always tell my patients. Listen, I don't think you need a transplant now, and maybe a year or two away, and maybe even longer away. But at least having had that initial conversation, meeting the team, meeting the doctor, and being like, they're not that scary. And they gave me, some good information. So, you just arm yourself with the tools that you need to be prepared for when it happens.
Yes, bravo to that. I'll second that. And also, we know so many people now that are post-transplant 5, 10, 15 years out, and they're doing great. They've done, it's been very successful. Could you discuss the clinical trial related to the drug to decrease inflammation and cytokines? Is this only for MF? It seems that many of the symptoms of ET, PV, and MF are all related to inflammatory responses. We hear this quite a bit. And I know Dr. Fleischman has done some studies on inflammation and MPNs, but what are your thoughts?
I'm not sure what trial the person
Yeah,
that's
I'm not
asking
sure
the question
either.
is
I
referring to,
don't know
but
what trial.
there's lots of clinical trials with lots of different medications, and a lot of them are looking at responses to inflammation. In fact, the first ever drug approved in MPNs was ruxolitinib, and that was approved, over a decade now. And that also demonstrated that it lowered inflammation in these diseases. And so one of the things that these diseases all have in common is that they are, in fact, associated with elevated levels of inflammation in the body. And the reason why people feel better with medications like ruxolitinib or jakafi is because it lowers the level of inflammation in the body. And you're right that this impacts not just myelofibrosis, but it impacts polycythemia and essential thrombocythemia as well.
Does the white blood count, if it's less than 20, suggest a more aggressive disease?
No, if it's greater than 20, suggests a more aggressive disease.
I mean, greater than 20. Yes. Okay. And what is the actual underlying cause of fatigue symptoms that come from MPNs?
Yeah, that's the $1 million question, huh? So like I said, fatigue is a difficult symptom, and it's a multifactorial symptom. And what I mean by that is there's more than one thing that causes fatigue. Anybody in the world experiences fatigue at some point in their life, right? And probably at some point during the day. And so fatigue can be caused by a lot of different things, from stress, anxiety, depression, not sleeping well, taking lots of medications for other medical issues. So many different things can impact fatigue. From an MPN perspective directly, we were just talking about inflammatory cytokines, or these molecules that are associated with elevated inflammation. That probably also contributes to the feeling of tiredness that MPN patients experience. But I think one of the things I try to talk to my patients about, which I think is really important, is it doesn't ultimately matter that you can identify 100% what your fatigue is related to. What matters is that you try to tackle it in multiple different ways. And so I'll give an example that we were just talking about previously. If I have a patient that can't sleep, well, no matter how much I do in terms of managing their MPN and give them medications to control their blood counts and those kinds of things, I give, I'm never going to make that patient feel energetic. And so, that patient, in addition to seeing me, also needs to figure out, I can help to some degree, but I'm not a sleep specialist, needs to figure out how to improve their sleep. If a patient has sleep apnea, for example, and part of the reason they're tired is because they don't know how to utilize a sleep apnea machine, again, no matter what I do as an MPN doctor, I'm never going to be able to fix that. And so tackling all of the different things that can contribute to fatigue is really important. And that includes, dealing with other medical problems and then dealing with what you can deal with from an MPN perspective. And so from an MPN perspective, there's kind of two parts of the approach. One is, do I need to be on a medication like a JAK inhibitor that can potentially help improve my fatigue? Yeah, maybe. Sometimes when you lower blood counts, normalize blood counts, or take a medicine that lowers the inflammation levels in the body, that can improve fatigue. But I'll tell you from experience, that rarely takes it away completely. And so other things like making sure that you have a sleep routine that is conducive to feeling well, going to sleep at the same time, waking up at the same time every day, waking up and doing exercise, for example, also really helps. The body loves routines and cycles. And so if you can do the same thing every day where you go to sleep at the same time, wake up at the same time, wake up and exercise, have a good meal in the morning, and then try not to sleep too much during the day. And if you do need to take a break in the middle of the day, make sure that it's a short nap, and it's not too close to your bedtime. All of these things kind of set you up for having that good circadian rhythm, that good routine in your body, and can help tackle fatigue. And you're not just tackling it by doing one thing, you're doing several different things to kind of maximize everything.
Mhm, mhm. I know fatigue is actually, the fatigue study, that was like one of the biggest studies, that addressed fatigue. And we have Natalie who, does a lot of yoga. She's just starting a whole series again.
Right.
And just doing stretching and meditation, just getting your
Helps so
mind off
much.
what's going on. And I actually read Dr. Sanjay Gupta's book about the brain. And one of the things he really stresses is, not to drink water at a certain time before you go to
Right.
bed, not to look at your
Exactly.
phone, or,
Right.
be involved in electronics, a couple hours before you go to
Yeah, it's all
sleep.
great points, Anne, for
I
sure.
mean, all those things, that contribute to poor sleeping habits. But anyway, I'll move on. Let's see, there's so many questions here. Does Jakafi cause any anxiety, depression, and a detached sensation? Can Jakafi impact thyroid function?
I would say no. If you're having those symptoms, I think, again, going back to our theme, you can have more than one thing going on. I would probably talk to your doctor
Yeah.
about that.
When myelofibrosis enters the picture, when is someone considered post-PV?
If somebody has myelofibrosis and they had a diagnosis of PV before, then by
Oh, that's just,
definition, they're post-PVMF, or what's also
okay.
called secondary myelofibrosis. So if you had ET or PV before and then it turns into myelofibrosis, that's it. That you're post-PV or post-ETMF.
And Gabby, I know there are lots of studies coming up, and we talk about progression constantly. And
Mhm.
we read a paper by a German group that actually figured out kind of how to look at genetically who might progress to what and when, like how that would work. And we're going to do more with this German group and talk more about it. But have you, in your years of working with MPN patients, are there any red flags that say, okay, this person is definitely going to progress or has progressed? And what are
Well,
those?
we have the risk stratification scores that we
Yeah,
utilize, and
yes.
those take into account, blood counts, symptoms, and mutations. And there are, yeah, so those can really help you to know that. And along those lines, there's another score called the RR6 that helps to understand how patients are going to do on Jakafi, or if they need to change from Jakafi to something else. So that also helps with prognosis a bit. We know that patients that don't get to the right dose of Jakafi, that end up needing transfusions and don't have good control of their spleen, probably have higher risk disease, even though those three factors that I just mentioned aren't necessarily included in the prognostic scoring systems. And so there's different ways of kind of identifying patients that are high risk.
Is failure of ruxolitinib to control blood counts indicative of an underlying problem? My wife has a P53 mutation and the JAK2 mutation. Could the P53 mutation interfere with the efficacy of ruxolitinib? Great question.
P53 does not interfere with the efficacy of
Okay.
ruxolitinib. P53 is just a mutation that makes it so that her blood counts may get worse faster than they would otherwise. It has nothing to do with jakafi itself. And so, yeah.
Do blood transfusions help with PV symptoms?
Yes. But I would say, but I would say for PV, people probably do not need a blood transfusion because they have too much red blood cells. So giving them a transfusion would not be helpful. For myelofibrosis, if they're anemic, meaning their red blood cell levels are low, then a transfusion can be helpful. But remember, a transfusion is a Band-Aid. It is very short-lived.
All right, so this patient says, my doctors are telling me I'm anemic, but my hematologist says, no, I'm not, because my iron studies are normal. Why would there be that, why would that discrepancy be there?
Sounds like your doctors need to review the definition of anemia, but anemia is not just iron deficiency, and this is a very common misconception. So
Right.
there are many different things that can impact anemia. So what is anemia? Anemia is just the medical term for low levels of red blood cells. And to make things confusing, we have different measures of red blood cells. So you have the RBC number, you have the hemoglobin, and you have the hematocrit. Forget about what they each mean. They're all measuring the same thing, the red blood cells. All right. If you do not have enough red blood cells in your body, then you're anemic. You can become anemic in different ways. If you don't have the ingredients to make the red blood cells, then you can become anemic. So if you're missing iron, you're missing B12, you're missing folate, these are the ingredients to make red blood cells. If you've bled out from a accident or something like that, well, you're going to be anemic in that moment because you've lost blood. It has nothing to do with your bone marrow or with the ingredients. It just, you've lost blood. And then from a myelofibrosis perspective, if your bone marrow or the factory that makes blood is not working, you can give somebody all of the iron in the planet, they're still going to be anemic because their factory can't use those ingredients to make the blood. And so if your doctor is saying, no, you're not anemic because you have enough iron, well, that's not true. You just have enough iron, but you can also be anemic because your bone marrow is not working the way it should.
I'm so glad you said that because I used to be anemic as a child, and every now and then I probably am. I just don't get checked, and I can kind of tell when I feel a certain way. But all right, so this is interesting. My head and body, we hear this all the time about body aches with MPN patients. My head and body ache all the time for no apparent reason. I was told by a neurologist that PV causes my blood cells to enlarge and be misshapen, and they may be pressing against nerves or smaller blood vessels. What is your opinion?
I don't know how to answer that. I don't think that's what's
So the
going.
body aches and the headaches and stuff, we hear
Oh, I
that
see. No, I think
often.
that's more
Yeah.
related to the inflammation in the body that is elevated in myelofibrosis. The blood cells may be more active than they would otherwise, but that's not what's causing the pain. People that have sickle cell disease, the red blood cells don't have the right shape, and so they get stuck in blood vessels, and that can cause pain. That's not what's happening here. Here you're having bony pain because of these inflammatory cytokines or these molecules that increase inflammation in the body.
I know there's,
So fatigue and itching and all those things, they're all
yeah,
related to
it's so
these.
crazy. Those symptoms are just terrible for some patients,
Yeah,
and we're always looking at ways to mitigate those. But
yeah.
um, what are the long-term effects of taking hydroxyurea?
Yeah, that's a good question. So generally speaking, we think of hydroxyurea as a safe medication, and it has not been associated with increased, transformation to myelofibrosis or to leukemia. But it hasn't been studied super strictly. We haven't done like what's called a prospective clinical trial moving forward to say, all these patients that had hydroxyurea were followed for 3 decades and they didn't develop leukemia. And so we don't, we generally think that it's a safe medication. People can take it for many decades. Children with sickle cell disease receive this medication and they take it for a long time. So I would say it's generally a safe medicine. Now, that being said, if I had a choice to pick in a young person, like in their 20s or 30s, and they needed to be on a medication to lower their blood counts, I probably wouldn't choose hydroxyurea. I would choose something that is non-chemo, like an interferon, simply because, like I said, we don't have data that says if you're on hydroxyurea for 5 decades, will you have a higher likelihood of progression? And so I think it's important to understand the limitations.
Are there any new developments in MPN unclassified? Are these patients unable to participate in clinical trials?
Sometimes they're unable to participate in clinical trials. And sometimes they can. And so it really just depends on the clinical trial, and that's an important thing to recognize. There's not a group of patients that's always excluded from trials. It's just harder to make trials for MPN unclassifiable. So there's been a few trials that include those patients, but for the most part, that is still an unmet need.
This patient says they've been on hydroxyurea since November and saw elevated liver enzymes. Is there anything that person can do to strengthen their liver or to mitigate that problem?
No, so that's a very individual question that I can't answer. I would say that that's something to talk to your primary care doctor and your hematologist or MPN team about. There's many, many different things that can elevate liver function tests. And so it's important to know, are these abnormalities because of the hydroxyurea, or are these abnormalities because, you just started a new medication to control your cholesterol or something like that. And so many different things can impact the liver function tests.
We hosted an event in Asheville last year with Dr. Messa, and I'm trying to think of who addressed the liver issues.
Okay.
Dr. Brandy Reeves. Yeah.
Okay.
So that for this patient, it is on our YouTube channel. You could check that out. Is there a risk of taking sumatriptan long-term for the treatment of migraines with ET? This person has ET, considering, the work restricting the blood vessels in the brain and so on. Does that
Well,
affect
something
it?
that's been studied, but it goes back to what I was saying before in terms of fatigue and addressing many things that can contribute to fatigue. Headaches is a great topic, just like fatigue.
Yeah.
Many different
Yeah.
things can cause headaches. And although the MPNs can be associated with headaches, in particular ET, if the treatment for the ET is not getting rid of the headaches, then you need to manage the headaches independent of the ET. And I refer many of my patients to a headache specialist. And so if sumatriptan works for you, then you should take sumatriptan. I can't tell you the ins and outs of sumatriptan. It's not a medication that I prescribe that frequently, but there are not studies looking at sumatriptan and ET. So I would say plenty of my patients are on sumatriptan and do fine.
Yeah, because we did a survey with about migraines, and it was phenomenal. It was I mean, almost every woman that responded had migraines that suffered from migraines and MPN. All right, I have the MPL gene mutation, and my symptoms seem to be more progressed. Can this be due to the MPL mutation or something else?
Again, these are very specific questions, so I can't really say that specifically to you. Less is known about the MPL mutation than the JAK2 and CALR, simply because MPL is not that common. If you feel like your symptoms are getting worse, then I think it's important to talk to your doctors about that. So it's not specifically that your mutation, makes it so that you have symptoms that other patients with other mutations don't have. Each person is individual, and their response to treatment is individual. And so I would say, if a medicine that you were taking was controlling symptoms before and now it isn't, then it's important to talk to your docs.
This is a great question because it comes up quite often. There almost seems to be two or three different camps, in terms of when to treat, when not to treat. I'm a PMF CALR diagnosed 6 months ago and put on watch and wait. What are your thoughts on early intervention versus waiting?
I think that if your blood counts are fine and you don't have symptoms from your disease, In 2025, we don't have a treatment that can prevent progression. And so I would say watch and wait is really the appropriate thing to do.
Okay. How does a positive M strike affect disease burden? I don't know what
I
that
think we're talking
means.
about something else. So M spike, I think is what they're
Oh,
trying to say.
maybe spike. Okay.
Yeah.
I don't-
And M spike is related to multiple myeloma, not to MPNs.
Uh-huh.
Now there's some
Yeah.
patients that have both, the MPN and either multiple myeloma or the precursor condition called MGUS. They're not related to each other, and so both of them need to be thought of separately. So sometimes patients may need therapy for the myeloma part of things because that's what's getting worse. But because you have an MPN, if you also have multiple myeloma, then your blood counts may be more sensitive to changes with the medications for multiple myeloma, but that's pretty rare.
How does not having a spleen affect decisions for medication and moderating or monitoring disease progression?
Not having a spleen doesn't change anything. I mean, the biggest change of not having the biggest impact of not having a spleen really is that most clinical trials require having a spleen in order to be considered eligible for the trial.
Yes.
Um, but if you don't have a spleen, it doesn't change how your doctor figures out if you have progression or not. We look at it the same way. Are your blood counts getting worse, or is your bone marrow getting worse?
Great question here, and we get this quite often. Can you speak about the difference between BESREMi and Pegasus from an efficacy perspective?
Yeah, great question. And I can't actually. They've never been studied head to head.
Yeah.
There's never going to be a study that compares them head to head. Nobody would be interested in paying for that. I would say that just indirectly, they're probably similar in terms of efficacy. Um, and they've both been shown to lower the level of the JAK2 mutation over time when they're taken. The biggest difference really and this is really important as this is a patient audience, is the experience that the patient has. And that's in two main ways. One is, and this may sound trivial to those that aren't giving this medication or taking this medication, Pegasus doesn't come in a pre-filled syringe. You have to fill it yourself. And that may sound easy, but for some people that's actually really hard. And like the amount of Pegasus that you need to put in the syringe is tiny. And so that can be really difficult sometimes. Whereas BESREMi or ropic interferon comes in a pre-filled syringe. So that's nice. You already have everything kind of done for you. Pegasus is given once a week, whereas BESREMi is given every 2 weeks. Now, that being said, when patients have their blood counts well controlled, Pegasus can also be spaced out and given less frequently. I have several patients that take Pegasus once every 5 weeks, 6 weeks, 7 weeks, 8 weeks. They take it not that frequently either. Um, and so that is maybe less significant, but I would say that Pegasus probably has more side effects than does BESREMi. BESREMi is better tolerated simply because of the way the medicine is made. And so my experience has generally been that there's less adverse events or less bad side effects with BESREMi than with Pegasus. Although again, I've had plenty of patients that are still on on Pegasus and have been on Pegasus for years and tolerated just fine. And so I would say, BESREMi is the new shiny exciting medication, but if your insurance won't cover it and you can only take Pegasus, don't feel like you're missing out. It's still a perfectly viable option. Many people do really, really well with it. And then I would say, and I just had this conversation yesterday with a patient, if the insurance doesn't approve BESREMi and requires Pegasus first, you can always try Pegasus first. And then if it doesn't work out for you because you just don't tolerate it or whatever, then your doctor can write an appeal to the insurance and say, Pegasus was tried, didn't
Yeah.
go well, let's try BESREMi. And so maybe that's not the most satisfying answer because as a patient, you're going to tell me, but I still need to try it and I don't want to. But again, most people do fine with Pegasus and start at a low dose and go up very, very slowly. And so people usually tolerate that okay.
Yeah, and we do have patients that actually, have trouble getting drug,
Yes.
Pegasus, and so they share it and they share it with other patients. It's really sad.
Yeah.
Um, let's see. Does the ratio between absolute neutrophils and absolute lymphocytes provide any scientific data about longevity?
I don't know yet. I mean, there's been some studies looking at the ratio and how that may be an indicator for poor prognosis. But I think a little bit more work needs to be done in that regard for us to start knowing how to utilize that in clinical practice, because right now we don't really do that.
Yeah. I can't believe all these questions. This has been great. Any new ideas to help with itching other than using a humidifier, lotion, antihistamine, and cold water?
Great question. And so itching is tough. Um, all of those things are really important, especially in the winter. I don't know where you all are, but in New England, we've been
Dry.
freezing, it's been dry, everybody's itchy. And so for sure, making sure that you have really good skincare, take short showers and really moisturize your skin after a short shower is really important. But besides that, I mean, ultimately, if you've tried all those things and you're still itchy, then I would recommend ruxolitinib. That's really the best medication for dealing with itching. And I have some
Mhm.
patients that are very hesitant because they don't want to start a medication just for something like that. But itching is a difficult symptom to live with. It really is. It's one of those things that, like a pre-filled syringe, just doesn't sound like a big deal. It is a really big deal. It's a really big deal. So if you're living with itching and you've tried all those other things, I would consider ruxolitinib. I really would.
Yeah, because we do know patients that started Rux and their itching issues went away, and
Few
patients that have
times have I
had the
felt like,
disease forever and they were
yeah,
going crazy,
yeah.
and they did have that taken care and that went away. Do you
I
know
feel like a
any?
magician when I give ruxolitinib to patients that have terrible itching, and I'm like, you are going to come back next week and you're going to tell me that you were able to take a long shower. And
Yeah,
and patients are like, oh my God, how did you do that? So
it's true. It's
there's
true. It's
limitations in our
great.
medications, and we definitely need some better medications for some situations, but few things will cure itching like ruxolitinib does.
Truly. Are there any connections? And again, we hear this very often, with blood cancers in families. Their father and brother both have CLL. My brother
Yeah,
has CLL,
yeah,
and I have ET. And, there are familial studies out there, but
yep. No, 100%. I mean, between CLL and MPNs, again, nobody's going to be able to tell you. There's certainly families like yours where things kind of run in the family. I met a woman yesterday who has JAK2 mutant ET, and her brother was just diagnosed with CALR mutant ET. And so obviously it's not just a JAK2 mutation that's the inherited thing, because you
right.
usually don't think of these as passed on from parent to kid, but there's certainly some genetic predisposition. And I think going back and to one of your questions about, earlier diagnosis, because people are diagnosed more now, because we can do genetic testing more now,
Mm-hmm.
I think we are finding more of these families. And so, you know, there's definitely some research into that, but we still don't have a great answer. And even now, like patients are like, should I go and get screened? Like, should I tell my kids to get screened and that kind of thing? And we don't really have an answer for that. We don't know if they should get tested
It's
or not.
interesting because it is an interesting question. And I know, again, Dr. Fleischman's doing a study. Dr. Wadley did a study years ago, and others have done familial studies. But we hosted an event one time, and there were 5 people, family members in the audience, and all 5 of them had an MPN. And
Wow.
so, it was wild. It was really wild. And it was so funny because one of the speakers said, "Oh no, there's no link to this at all," and there they were saying it was so funny. But anyway, their studies definitely need to continue, and we need to
Yeah.
continue to look at it. Do you stand firm on the hematocrit of 45? Is there room for variability?
What a great question. And again,
Yeah,
another place where we need probably more data.
yeah.
The study that gave us that number is called CytoPV. And, a quarter of those patients weren't on aspirin. Problem, and most of the people on that study were either on hydroxyurea, perhaps some of them on interferon, or on nothing. And so I think that it would be interesting to know, in 2025, if we did a study like that, where everybody would be on aspirin and we would have different medicines, not just hydroxyurea, or even if it is hydroxyurea, but and seeing if those numbers, that number 45 still holds true. There's several limitations of that study. Like I said, some of the patients weren't even on aspirin. They don't divide the groups by people that had cardiovascular problems versus those that didn't. So it's hard to know, if you're a young person that doesn't have any cardiovascular problems, do you really need to be under 45 or not? Like, we don't know that. If you're on
Mhm.
ruxolitinib, for example, or on aerobic interferon, can you have a different cutoff? Also, we don't know. The other thing too is that hematocrit is a difficult number too, because laboratories will measure hematocrit differently also, and it can be impacted by how iron deficient you are. And so many patients with PV are going to be iron deficient by definition.
Mhm.
And so, I think that that's again a study that I've been thinking about a lot in the last year, and it's just difficult to figure out how to find a population that's contemporary and relevant
Mhm.
so that we can answer that question, because sometimes for some people 45 is a difficult number to get to,
Yeah,
especially young
that's a great,
males.
yeah,
Like
yeah,
if
the
you go and
difference.
test a bunch of 16-year-olds, they probably all have hematocrits of 50. What are we going to do with them? Phlebotomize them?
Yeah,
Obviously not.
interesting. One time I was talking to a pathologist and he said, sometimes the path reports can be so different. Sometimes it's very clear, this is it, and this is what this person has, and this is where it is
Yeah, that's
located.
right.
And then you put five other pathologists together and they can find and have different opinions too. I've had PV for over 15 years and never had a bone marrow biopsy. Should I have one?
I wouldn't think so. If everything's good and you're feeling well and your blood counts don't look concerning to your doc, I wouldn't do a bone marrow biopsy just to tell you that you have a disease you already know you have.
Right. I'm 74 years old, a male with PV diagnosed 10 years ago, and I am taking hydroxyurea and aspirin. I have bouts of pruritus typically at night when I'm in bed. I take a shower usually 4 to 5 hours before bedtime. I took a teaspoon of Benadryl for about a year every night and got some relief. Recently, I did some research and learned that there may be some link with long-term usage of Benadryl and dementia.
Right.
I was sufficiently concerned and I decided to stop it and switch to Zyrtec, which
Mhm.
is not as effective. I know this is a thorny one. Any suggestions? That's great.
So I think I probably answered that before. I would say that if the
Yeah,
medications aren't working for you, then you should consider something like jakafi or ruxolitinib to help with the itching, because it sounds like it's interfering with your quality of life.
right. And this from a woman who wants to have a baby. Recently I was married. My husband and I would like to start looking at the possibility of raising a family. I have ET. What should I do?
Again, that is a very personal question, and probably requires knowing more about your history. But I think the important thing to know is that patients with MPNs can have babies. And we've studied it, I've studied it, and their outcomes are pretty good, actually. The most important thing is to be on an aspirin throughout pregnancy, and then to be on a medication called Lovenox for 6 weeks after delivery, establishing care with a gynecologist that's, we recommend like a high risk obstetrics person, but the truth is that they usually don't know that much about the MPNs either. So I'm not sure that they add a ton, to be honest, in my experience, but I think it's probably not a bad idea to at least think about that. Um, yeah, and I mean, if you've had a blood clot before, then you need to be on an interferon during pregnancy, but most people that have ET or PV that are young of childbearing age usually do not need to be on a medication like interferon.
Yeah, and the communication between your hematologist and the
It's
OB/GYN
really
or whoever
important.
that is really important.
And another neat
Um,
thing is when people with ET get pregnant, their blood counts actually normalize during pregnancy, which is kind of interesting. And so don't be
wow.
scared if all of a sudden your platelets are normal. That'll happen, and your hemoglobin will come down. That'll happen. That's part of having a baby that's eating up all your iron. And the white blood cell count can go up a little bit, and that's all right. Believe it or not, almost immediately after delivery, your blood counts will go back to where they were before.
Um, is there any truth that symptom severity can decrease with plant proteins versus animal proteins?
Oh, I love that question. I wish I could just say yes. That would be a great thing to say.
I know,
I
it's
would
a
walk
great
around
thing.
saying that. I think we've been talking a lot about inflammation and a lot about the fact that symptoms need a multi-pronged approach, right? Symptoms aren't just caused by one thing, and even if they are, you can still make them better by, treating many aspects of something. So, we hear everywhere plant-based this, plant-based that, before it was Whole Foods and whatever. They're all the same thing, right? We're talking about healthy foods that aren't processed, and having more fruits and vegetables and whole grains than we do meat. And I think that that really makes a difference. Like I was saying before, if you go to sleep at the same time, wake up at the same time, wake up and exercise, and then you have healthy food, all of that helps you with how you feel.
Absolutely.
It's good for
Mhm,
your cardiovascular system. It's
mhm.
good for preventing um, or managing, cardiovascular complications. And being active and with a healthy diet also lowers inflammation, because a lot of these foods, like very processed foods, or foods like animal proteins that are have a lot of saturated fat, like red meat in particular, or processed meats in particular, like ham and bacon and those kind of deli meats. Really, those things should be avoided a lot, and not just because of your MPN, it's just not good for your health. And so
Okay.
those things, by having the wrong types of fats, and those fats can be inflammatory. They can increase inflammation in the body. So
Mhm.
I think that the healthy diet and exercise approach is helpful to your well-being, to your cardiovascular health, and potentially can also lower overall inflammation and improve symptoms. So I love that, and I
Yeah,
definitely recommend that.
absolutely. And the way food is processed here is
Yeah,
not great. So
not
you,
great.
you really have to do your homework to go shopping.
That's right.
And, but also, even walking, I'm a walker, and I will tell you that it is one of the best things I do every
A
day.
hundred
And,
percent.
after a meal, especially, just even, you don't have to walk fast. You don't have to walk 5 miles, but just do something, that
Just
is
do
moving
something.
your,
Absolutely. Yeah.
yeah,
Yep.
yeah. I have heard that MPN specialists are okaying the use of baby aspirin twice daily to keep the medicine in your system longer. What do you think about
Yeah,
that?
some people advocate for that, and I think there's some situations where that makes sense. So some people have headaches or numbness and tingling in their hands and feet, and they feel like, I take my aspirin in the morning, and then by nighttime I have those symptoms again. I think for those symptoms, it makes sense to try to take it twice a day if the symptoms are just not well controlled, because the platelets in ET in particular turn over more quickly. So you may have blocked them in the morning, but by nighttime you may have new platelets that aren't blocked, for example. Um, Patients that have a lot of cardiovascular problems, like they've had heart attacks or strokes or things like that, for sure, there's recommendation to consider aspirin twice daily. And this is not set in stone. It's something that's a consideration, and I recommend it for some patients.
So, for the sake of time and your work and your time mostly, what would you share with the people on at this webinar and after, because it is recorded and we get tons of hits from all of these. Um, what wisdom would you impart to new MPN patients that are with us today? And what do you see in the future? What hopeful things do you see in the future for MPNs?
Great, thank you, Anne. So for new patients, I would say, it seems scary, for sure, but surrounding yourself with good information, or filling yourself with good information, is so important. And so the internet is a wonderful place, but it's also a terrible place. And so be careful with where you get information. Joining webinars like this, going to patient advocacy organization meetings in person, going to the NCCN guidelines, the American Cancer Society guidelines, Leukemia Lymphoma Society guidelines, MPN Research Foundation, like all of those pages have good information that's been vetted, that sends you to the right place. Be careful with some of these online social media type groups. Although it's nice to feel like you're part of a community, and I totally get that, remember that sometimes folks that are online in those groups are maybe not representative of all of the patients. My patients that are
Mhm.
doing fine and working and leading their lives and doing all the great things, even having kids, like somebody was asking, are probably not on these groups posting terrible experiences. And so you just need to be aware of that. And I spend lots of time in my clinics every week talking to patients about misinformation that they've gotten online, and it can be really scary for patients. Um, and so along those lines, in addition to getting good information and being careful with bad information, make sure that you have a good relationship with your physician team. I think that initially you're going to have a lot of questions, and things may feel a little bit scary. being able to go to that visit prepared with questions is so important. You're going to get so much more out of that visit if you go with a notebook where you've written down questions like, "Oh, doctor," or or your nurse practitioner, or "You said this last time, I didn't understand what you meant by that," or "I've been feeling this, is this an issue?" It's really important. So you make sure that you get what you need out of that appointment. And then, and this is true for every patient, not just for newly diagnosed patients. And in general, both for the newly diagnosed as well as the veteran patients, so much has changed in the field of MPNs in the last decades. I mean, in 2005, we discovered the JAK2 mutation. In 2013, the CALR mutation. In 2011, ruxolitinib was approved, and now we have 4 JAK inhibitors approved. And there's countless clinical trials. I can't even keep up with them almost. So know that there is interest in your disease. You're not alone. And a lot of doctors and folks in the field are very, very dedicated to improving the outcomes of patients with MPNs. And so thank you for joining this webinar and asking these great questions. Feel hopeful because I really feel very optimistic that we're going to have excellent treatments in the next couple of years.
I do too. And thank you so very much. We know how valuable your time is.
It
And
is my pleasure always.
great questions answered. And for those of you that want to watch again, this will be recorded and probably back out by Wednesday. Wait, today is Tuesday, so maybe tomorrow. So it will be. But anyway, Dr. Hobbs, I will be in touch with you because I'd like you to join us at the women's event in Chicago, the
Fantastic.
last Friday in September, but I'll get that information to you. And again, thank you so very much.
Thank you so much for having me. Thank you, everybody.